Good day, good afternoon, good evening, everyone in the world listening to this ESR Connect webinar. Welcome. This ESR webinar is organized in collaboration with the European Cancer Organization, ECCO. We will talk today on a highly interesting subject, the impact of the COVID pandemic on cancer screening. As you know, in many countries, the screening programs have been suspended during the COVID crisis to minimize the risk of transmission in healthy people. So what that means and where we will stand now with screening programs, you will hear today in this hour. I would like to introduce the speakers of this faculty. They will introduce themselves in more detail, but I can tell you that we have composed a session with high experts. Professor Hans-Ulrich Kauczor from Heidelberg, Germany, Professor Sofia Zachrisson from Sweden, Malmö, and Professor Evelyn Decker from Amsterdam, the Netherlands, will share with you their experiences on lung cancer screening, breast cancer screening, and colorectal cancer screening. I am Regina Beets-Tan. I'm the head of the radiology department in the Netherlands Cancer Institute, and I'm happy to chair this session. So I would like to give the word to Professor Hans-Ulrich Kauczor to introduce himself, and following him, also the other speakers.
Thank you very much, Regina. Good afternoon, everybody. My name is Hans-Ulrich Kauczor. I'm a chest radiologist by training. I'm head of radiology and chairman of radiology at the University of Heidelberg in Germany. And I've served as a former president of the European Society of Thoracic Imaging, as well as the Fleischner Society. And currently I'm also head of a department on translational pneumonology and being a member of the German Center of Lung Research.
Thank you. Yes.
So good evening and hello. So I'm Sofia Zachrisson, and I'm professor of radiology at Lund University in southern Sweden, and I'm also a senior consultant radiologist at the Department of Radiology in Skåne University Hospital in Malmö. And my main both research and clinical area, and I'm currently running, or I just finished running a large screening trial investigating 3D mammography screening. I also have a role as the Vice-President of the Swedish Society of Breast Imaging, and I'm also a board member of European Society of Breast Imaging.
Thank you. Professor Decker. I think you have to unmute yourself. We don't hear you. Can you unmute yourself?
Yes, that's it.
Yes.
Sorry. My name is Evelyn Decker. I'm a gastroenterologist at the Amsterdam University Medical Centers in Amsterdam in the location AMC. And my job is mainly being a practicing gastroenterologist in my center, but also I'm doing a lot of research concerning colorectal cancer screening in average risk individuals and also in high risk individuals. Besides, I'm currently the global chair for the WEO CRC screening working group, with over 1,300 members, focusing all over the world on CRC screening programs and trying to optimize them.
Thank you very much. So, as you've heard, it's an excellent, outstanding faculty, all who want to share their experience. So, I encourage you to listen to them. They will all give short lectures. And after that, we will go into the final part of the session, which will be a question and answer, some debate. So, please feel free to send your questions to the chat so I can select them and put forward to the speakers. So I would now like to hand over the microphone to Professor Kauczor for his talk on lung cancer screening. Thank you.
Okay, thank you very much, Regina. So we will start. It is how to keep up the screening programs in lung cancer. Next. And so this is my conflict of interest disclosure. Next. I will start with the evidence and just highlighting 3 major randomized trials and their results, how it came about to screen lung cancer by using a low-dose CT. This is the original big American study, the National Lung Screening Trial, and on the left-hand side, you will see the cumulative number of lung cancers. So in the CT arm, more cancers were detected than with chest radiography. But on the other hand, regarding the lung cancer death, there were less lung cancer deaths in the low-dose CT arm, related to a 20% significant reduction of lung cancer mortality and to a 6.7% reduction of all-cause mortality. Next. So this evidence was then confirmed by the large trial in the Netherlands and Belgium, the Nelson trial, same plots shown, and they found a 26% reduction of lung cancer mortality in men and an even higher reduction of lung cancer mortality in women. It's not completely unclear from the data that have been published whether all-cause mortality was significantly reduced. Next. The very recent results of the German randomized trial nicely showed a significant reduction of lung cancer mortality in men of about 7%, but at the same time an almost 70% reduction of lung cancer mortality in women. So this is the hardest indication that there is a gender issue in lung cancer screening using low-dose CT. In this study, no reduction of all-cause mortality was found. Next. And because of all these data from the European Society of Radiology together with the European Respiratory Society set together and put a second edition of their joint position paper on lung cancer screening, which was actually published in the very beginning of this year. Next. And we decided to go a little different way, not just reviewing the evidence, but addressing critical topics that need to be taken into account when setting up lung cancer screening programs. It's about patient participants' involvement, an overview of the activities in Europe, the participation rates and the risk models that should be introduced, the introduction of tobacco cessation, the state-of-the-art algorithms of management of nodules, overdiagnosis and harms of such a program, how to deal with additional incidental findings, molecular biomarker, cost effectiveness. So I actually recommend you all to look at this paper, which has been published in European Radiology. Next. So the current activities in Europe, there are ongoing discussions in many countries, especially after the Nelson results were published. And in January 2020, the first nationwide lung cancer screening program in Europe was actually launched in Croatia. Otherwise, there is no organized nationwide lung cancer screening program. There are pilot projects on the way, especially in the United Kingdom and Russia and Poland and Hungary and in Austria. There's screening offered through private services in Israel, Switzerland, and Spain. And there are current recommendations and statements released in France and Germany. Next. So from the joint position paper, there's an action plan for implementation of lung cancer screening on the European level. One is the advocacy by relevant European medical societies, which will go beyond the ESR and the ERS, including the European Association of Personalized Medicine and also advocacy groups of patients. It will absolutely need some development of a recommendation or even a directive by the European Council, but all this has been overwhelmed by the COVID pandemic, so it's not on top of their list currently. Next. The other points for the action plan is the formulation of minimum standards of how to do it, the regular surveillance of the latest evidence in order to push forward the need to implement these programs in a larger number of European countries, and the setup of an umbrella European registry and analysis, something that might actually be facilitated by the COVID pandemic. Next. In the meantime, from our data in Germany, we looked at the capacity to predict malignancy using risk models. These here are actually the UK, this model that's used in the UK project, and these are all the others that are available, especially modified Brock models, which will nicely increase the sensitivity and specificity for prediction of malignancy of a given nodule in a prevalence round and also in the follow-up rounds. Next. I will now come to how the COVID pandemic has affected programs or countries where they wanted to set up programs. In the US, the short-term follow-ups were performed regularly and the decision-making over the phone calls were done continuously. However, all the baseline screening activities have been interrupted, and I was told that they will actually resume this month. Also, the scheduling of biopsies and surgeries for suspicious nodules were interrupted, and they are now implementing also hygiene guidelines for participants coming back to the screening programs. Next. Croatia, as I said, was officially launched the nationwide program on January 14 this year with 16 sites throughout Croatia. And they were hit by an earthquake on March 22, which was actually quite coincidental with the COVID pandemic. And the Central Pulmonary Hospital, Jordanovac in Zagreb, was hardly hit. So all the activities have come to a standstill, and it's not yet clear how they will be reopening their activities. Next. Great Britain, all the screening activities were interrupted due to corona pandemic. They are relying on mobile CT screening units, and these were actually acquired and are now used for caring for non-COVID patients in remote areas, because most of the hospital scanners were declared so-called dirty scanners, and the mobile ones were clean scanners used especially for oncology patients. And they envisaged that they are going to release the scanners for lung cancer screening earliest in July, probably starting August this year. Next. This is a slide from Sergei Moroza from the Moscow lung cancer screening. They nicely put out their old study and the new measures, though everything has been halted for the lung cancer screening this year, and they are aiming at very high numbers. And these are the lessons learned from the first round, but also from COVID, that they will use protecting personal PPEs for personal and patients, advanced routing, structured reporting is new, review by a central reference center, second opinion, and they are using all these because they have implemented all these measures also for dealing with CT and COVID pandemic in Moscow as well. Next. The status in Germany is actually that we started to apply the official way to have it approved in the years 2017 and 18. So the Federal Office for Radiation Protection started their evaluation last year, and they were actually scheduled to publish their scientific report in May. This has been postponed, but probably will be published in July now. And this is the other big institute which has to look into these analyses. And also the release of their reports is postponed by 2 or 3 months. Next. The European Society of Thoracic Imaging Lung Cancer Screening Certification Project was started, and all the online training tools were out there, and we had a lot of participants looking at them. And then for the ECR and the ST, the physical attendance of CUT workshops and case-based session was planned, and the written examination was scheduled for the ST Congress in June. Next. But unfortunately, all these had to be canceled due to the COVID pandemic. Next. So the CUT workshops and case-based sessions have all been postponed to March next year, and the examination has been postponed to June next year. So in summary, early diagnosis of lung cancer has been slowed down. There will probably be more harm than benefit from not offering lung cancer screening to the risk population. Tobacco smokers may be more vulnerable to contracting COVID and in higher risk of developing severe COVID, and the certification of lung cancer screening radiologists has been slowed down. Thank you very much.
Thank you very much, Hans-Ulrich, for this excellent overview on lung cancer screening. I would like to proceed to the next speaker. Before I think I will do this all lectures consecutively and hold the questions for during the panel discussion. So now the microphone is to Professor Zachrisson. Sophia, please tell us about the breast cancer screening.
So thank you. Great introduction. So now we switch from lung cancer to breast cancer. And in this slide, you just briefly see the overview of my learning objectives here. So we can go for the next slide, please. And this screening program is a very established one, as you probably all know. Many countries in Europe and worldwide have established population-based screening programs for breast cancer. And what I show here in this image is the current recommendation issued by the European Commission Initiative on Breast Cancer, and you have the link below. This is also a very good place to find all the evidence behind mammography screening. Just to summarize, we know that regular invitation to mammography can decrease breast cancer mortality with around 20%. And of course, that number is higher for the women who actually attend the screening. So the current recommendation, at least in Europe, is to invite women in the ages 50 to 69 years and to be screened every 2 years. Next, please. Now we do have different adaptations in different areas and countries, both in Europe and worldwide. So for instance, in Sweden, where I work, we have a broader age span from 40 to 74 years. And we also practice a shorter screening interval for women younger than 55 and a longer one for women over 55, due to the fact that we know that the sensitivity of mammography to detect breast cancer is lower for women with dense breasts. And those are usually the premenopausal women. But I would say that on average in Europe, 2-year intervals is the most common one, while in the UK, for instance, they have a 3-year interval for screening. So when we talk about breast screening, we are talking about women with average risk of getting breast cancer. We're not now focusing on the women who carry like a BRCA1 or 2 mutation, who have a very high genetically coupled risk of attaining breast cancer. But for women with average risk, digital mammography is the current recommended method. While there is a very vivid discussion on whether we should perhaps go towards a more individualized screening program, since, like I mentioned, we have a challenge with mammography, which is a two-dimensional method. And we have an issue with the women who have more dense breasts, like you see in the lower image. The woman to the right has a very high proportion of glandular tissue, making it more difficult to detect the cancer. So there are several interesting imaging approaches, for instance, 3D mammography or tomosynthesis, which is minimizing or reducing at least the overlapping tissue effect that you have in mammography. And there are several studies that have been performed and also that are undertaken right now, comparing 3D mammography with regular mammography screening, showing that we have at least a 30% increase in cancer detection with this method. But the outstanding question now is rather, are those relevant cancers that we detect, do we necessarily see an increased effect of reducing breast cancer mortality with this method? For the women with a very dense breast, there are also efforts to try ultrasound and also magnetic resonance imaging, since this is the most sensitive method, and to see if that is actually a better choice for these women. And not the least, artificial intelligence, AI, is of course of high interest in this area, and it can be used for very many objectives in breast screening. So if we would look ahead 10 years, perhaps, this is maybe how it could look like if we go from a more one-size-fits-all breast screening to a more stratified version of breast screening. And you could envisage that you do a stratification based on the woman's family history of breast cancer, the breast density on the mammogram and other features, and perhaps with the addition of genetic testing. And then you could stratify women into different risk groups, while it's thought that the majority of the women would actually end up in the median risk group, as you see here. And then you could then offer a more individualized choice of screening method, where you perhaps have a more technically advanced and more time-consuming and costly method used for the high-risk and very high-risk groups. And when it comes to AI, we don't really have time today to go into all the possibilities that we could use AI for in breast imaging. When I say AI, I mean machine learning or deep learning based softwares that can help us either detect cancers or predict a breast cancer risk, for instance. And this is just a list of the many very applications that you could use it for. Since in many countries we do have a shortage of breast radiologists, this could definitely be of great interest to see if we can reduce the workload. But all in all, both the stratified screening approach and the use of AI needs more prospective trials actually to show effect. Now to this other theme of today's talk, that's what's happened with breast screening during the COVID era. And again, we can go to this information corner at the European Commission website, where you can find a list of statements and documents published from different societies. And in the next slide, I show a couple of examples. One is from the editorial board of the Breast, a journal, and then we also have the French joint effort from different screening societies to recommend how we should do breast screening and breast imaging during this period of time. And to summarize what's normally said in those papers is that screening average risk women is not of high priority, of course, which is a reasonable choice, I think. So if we look at what happened in different parts of Europe, the strategies have really differed. In many areas, breast screening has been put on hold, but in some areas it actually continued with measures taken for social distancing, etc. But in most areas, for symptomatic patients, the clinical breast visits and also biopsies for highly suspicious finding have remained open in most areas, but with some delays. And I conducted a very unscientific survey among my European colleagues and some other contacts that I have worldwide to see what happened with screening in their centers. And as you can see from this table here, the majority of the places actually stopped screening during at least a couple of months. While in Sweden, it was partly open because in our country, this pandemic has hit very differently. Like where I practice in southern Sweden, we had a very low intensity of this pandemic. So we remained open with somewhat reduced capacity. And in Denmark, they closed a lot of the parts in society, but they actually kept the screening open. And so when will this reopen? Actually, most of the programs already reopened during mid-May to June. But they're all working with a backlog, of course, and with a somewhat lower capacity due to the fact that you need to keep the social distancing and the safety for the personnel, etc. And like in Sweden, where we also screen women over age of 70, we either try to find solutions for those women to come in separate times or actually to wait and re-invite those women later this year. So will this then have any consequences? Well, we will have somewhat prolonged intervals for screening, I guess around 2 months on average, but in some cases perhaps up to 1 year, depending on how long this pause will be. And we could also have a risk of getting lower attendance rates because people are still very cautious about moving around in the society. And then we could, of course, expect that we have larger tumor sizes at diagnosis. But will it necessarily have an effect on outcome? I'm not so sure. And I would like to give you just a brief background on why I don't think it will have a major consequence. So if we look at breast cancer from a biological point of view, it's a very heterogeneous disease. We have some very fast-growing tumors, and then we have tumors that are almost non-progressive and would never have surfaced clinically during a woman's lifetime. This is what this schematic image shows. And of course, with screening, we want to find a cancer before it's detectable with symptoms. So we can have the next slide now, yeah. You can also talk about it as of the sojourn time. And this is the middle period in this schematic image here. So this is where we want to intervene with our screening test during an asymptomatic but detectable disease. And the time from which the tumor cells start growing and that it actually gives a symptom has been modeled in many papers, and I just give a couple of examples here. And as you can see, you have a higher or a faster growth rate in younger women than you have in older women. And you look at the screening ages 50 to 59, it seems to be somewhere between 3 and 4 years, while it's around 5 years or higher in older women. So with an addition of 2 or 3 months to screening, it should not have a major effect on tumor size. But of course, for some individuals, you could drop over to a symptomatic phase if you postpone screening. And we also know from many studies in breast cancer screening that the majority, or at least 60 to 70% of the cancers that we detect in screening are actually stage 1 cancers. It means that they are less than 2 centimeters. I believe that the average size of a screening detected breast cancer is around 15 millimeters. And it also has usually no spread to the lymph nodes. And if we, in the next slide, look at survival rates, the 5-year survival for different stages as diagnosis, you can see at stage 1, of course, has an almost excellent survival, while stage 2 cancers, that is then 2 centimeters or larger, has still a very, very good survival rate. So based on these facts, I don't think that a prolongation of 2 months or 3 months would be of major effect on the population level. Being an epidemiologist, it's been interesting times, I can tell. But as an epidemiologist, I also know that you need time to follow up and see what actually are the true effects. I believe that for some individuals, we will see a significant delay in diagnosis, but this is mainly perhaps true for symptomatic women that have had to wait for their diagnostic workup, for instance. But on a population level, this will probably not be an issue, as I mentioned. So my take-home message is that most probably no substantial effects on COVID break on breast screening outcome, that is breast cancer mortality. And this is, of course, given that we don't have a longer break coming up this fall or so during a second wave. So what we should focus on now is to encouraging the women to go to their screening examinations and to reschedule if they actually did not attend during the COVID pandemic, and then focus on minimizing diagnostic delays in symptomatic women. And as a final remark, the European Society of Breast Imaging has formulated recommendations for breast imaging and cancer diagnosis that will be published shortly on our website, usobi.org. And that's all from my side. Thank you for listening.
Thank you very much, Sophia. Very interesting overview of the breast cancer screening. Very interesting. I would now like to give the word to Professor Decker, Evelyn, who will share with us the status of colorectal cancer screening, also a big killer. Please, Evelyn.
Yes. Thank you very much, Regina. So indeed, my topic is colorectal cancer screening. Next slide, please. So colorectal cancer has a high incidence. About 5% of the Western population will sometime during their lives have colorectal cancer, and it has very benign precursors that are clearly identifiable, and those are polyps of different sorts. Detection of colorectal cancer usually is in a late stage when we wait for symptoms. And that is why mortality of colorectal cancer was relatively high at a 40% rate. Mortality, however, depends, like for many other cancers, on the tumor stage. And you can see that above. Of course, the early cancers are better treatable than the metastasized cancers, also at less burden. So population screening for colorectal cancer, of course, aims to detect the cancer at an earlier stage or maybe even prevent it. And that's, I think, very different from other cancers because we can detect also precursors, remove them, thereby preventing the occurrence of colorectal cancer. And then, of course, the ultimate aim is to reduce the mortality, but also have less disease burden and have all this as at a cost reduction. So for every screening program, and this might be different in every region in the world, there is a balance between the benefits and the risks and the costs and the burden, and they depend on the type of screening test chosen and its characteristics, like the sensitivity and specificity of the test, the participation rate, but also its risks and actual costs and capacity and all those sorts of things. Next slide, please. We all know that colonoscopy is indeed the most sensitive method to detect colorectal cancer. However, it's not without a burden. Next one, please. For screening, also less invasive tests can be used, and blood in the stool is one of the most old-fashioned but also well-known types. It could select patients at a higher risk for advanced neoplasia, which is colorectal cancer plus the advanced adenoma, so the more progressed precursor lesions for colorectal cancer. And in that sense, blood in the stool could be used as a triaging method for those that should undergo colonoscopy. Yes, please. So guaiac FOBT is a very old-fashioned one, as I said. Those are numbers, as you can see here, from long time ago. All the studies were performed before the change of the era in both Scandinavia as well as in the US. And you can see here this very old-fashioned test that was just a very a qualitative test. It was either positive or negative with a little smear of blood of stool on a card. It already was able, this easy test in randomized trials, to reduce mortality of colorectal cancer in 16%. Next slide, please. The fecal immunochemical test is a new type of test, also detecting blood in the stool, but it has the advantage that it's a quantitative test, which means that it's really the amount of blood is measured in the stool. And that means that we can also vary the cutoff of that test. Besides, it only detects human blood and not, for example, a steak that has been eaten the day before will test positive as well. And it's an automated test, which makes high throughput easy. Next one, please. So, as I said, as we can vary the cutoff, there is it has possibilities, because it would mean that you can change the threshold at your discretion. So, if you need, if you want more blood in the stool to test positive, the sensitivity of the test will go up, as you can see on the sorry, if you test. If more blood has to be taken, the sensitivity will go down, but the big advantage is that the specificity will be better. So less colonoscopies have been done, but the test will do better. So it's always a trade-off between those two. Next one, please. So, as you can see here, this is the implementation of colorectal cancer screening programs across Europe. And you can see that most of the countries now, according to the European guidelines, have either already in place FIT screening programs. Some have still the old-fashioned guaiacs. And then there's several countries with other tests like colonoscopy as a primary test, or a non-invitation-based screening program, which means that individuals themselves have to ask for screening. Next slide, please. In the Netherlands, we chose for FIT, after having done many pilot programs to see both participation rates as well as logistics and feasibility for implementation. We started in 2014 for the population aged 55 to 75 by biennial FIT. Invitations nationwide every 2 years by postal mail, and we chose a certain cutoff. Next slide, please. The workflow and all the monitoring of the system is done by Screen IT, which is a huge data center, data warehouse, which is very useful because we are really able in that sense to monitor what's happening in our country with the screening program. And that is of use. And I will explain you a little bit how we use it. So the next slide, please. Before starting our Dutch screening pilot in 2014, we had expectations, and they were all based on our previous pilot studies. So we knew how many invitations we would send out because of the numbers in the country. We had expected a 60% participation rate, and we also knew the yield of the FIT with that chosen cutoff being 6% positive, and then resulting in a number of colonoscopies and then a number of patients with advanced neoplasia, with a positive predictive value of the test of 45%. Oh, next. So the results, however, in the first 6 months of screening, so right in the first half year, were that our participation rate for FIT screening when implemented nationwide was higher than we expected, 8% higher actually. So that resulted already in more positive tests and more colonoscopies to be performed. But the biggest surprise was the very high positivity rate. We expected 6%, but it was 12%. And that meant we had to more than double the number of colonoscopies to be performed for the screening program. Besides that, we looked at the positive predictive value of the test for those that undergoing colonoscopy, and then we found out that the PPV was a bit lower than we expected, 40 instead of 45%. So at that time, something had to happen because we had a shortage of the colonoscopy capacity, resulting in waiting lists, not only for our screening patients, but also for all those waiting for regular care in the hospitals. So what we really did not want, and we said that up front, we did not want to worry patients with a positive FIT, explaining them they could have cancer and then having to wait for colonoscopy for a diagnosis. And we really said at the beginning that this should not be longer than 3 weeks waiting time. So we needed action. And our Ministry of Health had to choose between two feasible options. One was to change the cutoff level, like I explained. It's a trade-off, but we would then increase specificity, but also relatively lower a little bit the sensitivity. Or we should have to just adjust the rollout of the implementation of the screening program. That would be the other option. But the Ministry of Health decided to increase the cutoff level. And we did modeling in my country, and we found out that probably then also PPV would meet the upfront expectations of 45%. Next one, please. Indeed, this came out because you can see here the positivity rate went down again. We changed from 12 to 6%, so resulting in the number of colonoscopies we were expecting. And then the next one is the result in the findings, the PPV. And here you can see that indeed the PPV went up, and now even a little bit higher than 45%, 48%. So about half of the patients that we scope for a positive fit do not have advanced neoplasia. They might have small polyps or other non-relative findings, but not the lesions we're looking for in the screening program, the relevant lesions. So indeed, real-time monitoring did show its success in this instance. And I'm explaining you this a bit better because it will do the same during COVID times. Next one, please. So what we also saw by our Dutch cancer registry in the Netherlands, that indeed, since the start of the screening program, the incidence went up, which is logical because we just detect more cancers in symptomless patients, but now it's going down. And I've just seen the first figures of 2019, and we seem to be lower now than the point we started at screening. So we really seem to find an effect also in preventing cancer now. Besides, we're looking at mortality rates, of course, the ultimate endpoint, and you can see we still kind of stable. We're lowering a little bit, but we need to lower a bit more because before we can say this is a success. But of course, this takes some time. Now, if we look at the European effect on mortality, there's different programs, as I just showed you in the slide with the map. There's a reduction of incidence-based CRC mortality for those invited compared to those who are not invited for screening. For guaiac, I showed you the results. Flexi-Sig, 3 big randomized controlled trials with clear effect with a reduction up to 30%. However, there's a bit an issue that these are all more participants than a nationwide invitational program where participation might be an issue in sigmoidoscopy screening. And then for FIT, still low number of studies and more predictions, but it seems to be around 36%, so more than double the guaiac effect. So it seems to be successful. In Italy, they've also looked a bit better, and they can show you also confirmative results, as you can see here, with a lowering incidence now and also a lowering mortality rate. So now a little bit more on the impact of the COVID on the screening programs in Europe. So here you can see what happened in the Netherlands. And now again, we had very much use of our monitoring system. We could see exactly what was happening. And this is what we did to the program. So on the above part, you see the number of COVID cases in the Netherlands that were registered nationwide. And you can see, of course, we had an early case, but then cases started really rising. And at a certain point in the dark red, our Ministry of Health decided to stop the screening program, to stop sending invitations. However, at that time still, please go back, still some FIT positives were showing up for colonoscopy. We had a stop, a total full stop for several months, from March 16th until mid-May. Then we announced that people still having their FIT tests at home could send them back. They would be analyzed and they would have their colonoscopy. And now, since the 2nd of June, we are restarting also to send new invitations within my country. How do we do that? That's the next slide. Why we do it is, of course, because the pandemic has an effect on cancer diagnosis. This has been published in Lancet Oncology, and it is an effect clearly on the green line on the lower hand, which is the skin cancer diagnosis. But also the pandemic has really made go down the overall cancer detection rate. And the blue one are all without the skin cancers. And this is not just the effect of the screening program stop, because we have seen also this effect is true in individuals younger and older than the screening ages. Next one, please. So we decided to restart, and again we use the system that we have in place for that, because we can exactly know through the system how many capacity all the colonoscopy centers have available for performing FIT positive colonoscopies, and they can all hand in their availability, and we can see that we are now at 62% of full capacity. We can just calculate back the numbers of patients we can invite for FIT screening, because we know all the different numbers throughout the logistics. Next one, please. If we look around the world, I've done also quite some inquiries with my colleagues. Almost all the programs have come to near or full stop, and they're all working on restart. All are coping with backlogs and waiting lists, but many don't have a clear system with monitoring like we have, so they have more difficulty in trying to target what's possible and what's not. Next one, please. So I think what's crucial in the program is the way we're doing now in Europe, advising to do FIT screening and having a test, a pre-test, a non-invasive test before sending all the patients directly for colonoscopy. So the primary colonoscopy screenings programs, well, I think they should really consider using FIT like they're doing in the US now. They are really promoting to do a pre-test, or maybe use other factors like risk factors. Sigmoidoscopy, already in England, they've decided they won't do the sigmoidoscopy screening anymore, especially now kind of come into speed due to the COVID. For FIT screening itself, there are several options as well, as if programs aren't able to catch up, because like we did, and I showed you, you can change your cutoff level, for example. At the cost of a little bit lower sensitivity, you will definitely increase specificity and do less unnecessary colonoscopies. You can change intervals or postpone invitations, that's other options. However, I think also lots of effort should be put in more other, maybe better non-invasive tests than FIT. And then last but not least, we do lots of surveillance colonoscopies for patients that had polyps in the past or cancer in the past. And I'm convinced we can do better there and do much less colonoscopies, and maybe even triage also with a non-invasive test. I thank you very much for your attention.
Thank you very much, Evelyn. Very nice presentation. I would now like to ask the slides of Europe. So I will just share with you briefly what is on the European level, what kind of initiatives are there. You've already heard a lot about all the different initiatives in Europe. Maybe yes, okay. So there are indeed, I think you also follow this program either on television or on the web. There are a lot of initiatives. We, European Society of Radiology, and the European Respiratory Society has last year organized an event at the European Parliament to call for EU initiatives to support lung screening programs across all member states. And I think it was successful because we could put this topic higher on the agenda of the EU. Next slide, please. Yes, the EU Commission is very much engaged into cancer care, and also cancer screening. The EU Commission really acknowledges the negative impact on cancer care of postponing screening and the treatment of the patients during the COVID. The EU Commission also had its initiative on breast cancer updated with 4 new guidelines, including the screening, to take into account the COVID-19 situation. And through communication by the EU Commissioner of Health, Stella Kyriakides, we learned a couple of weeks ago that the EU has invested and secured 9.4 billion euro only for health in the EU for Health program, which is about 20-fold the amount that was assigned in the previous years. So obviously this all will have an impact on the available resources for cancer care, including the screening. Next slide, please. Recently, the EU Mission Board for Cancer was established to identify missions that will address the main challenges in the cancer field. This mission, EU mission project, will be part of Horizon Europe, which is the successor of Horizon 2020, the EU Research and Innovation Program. And the next slide, please. The mission board has shown that screening is a high priority. As you can see, those are the 3 pillars. In fact, one of it is fully dedicated to prevention, primary and secondary prevention. And we understand that there are significant inequalities across the member states, and that you need to support and have a policy on screening. But we also recognize that it is the member state itself that are responsible to offer high quality cancer screening. So we have a very clear action that we would like to propose to the EU Commission to improve cancer screening in all member states. We would like them to reduce inequalities in access to cancer screening programs and in the quality of cancer screening programs. We would like to analyze which are the causes and which are the strategies to overcome these inequalities. Establish an EU research program to optimize existing research screening programs, but also to develop new screening and early detection methods, because that is important for cancers for whom we do not have a good screening tool in place. And it is also important to support programs that will raise awareness. And we believe that to emphasize on education and health promotion program among the young generation would be very effective. And last but not least, of course, it's important to have a high quality of screening. So we will recommend to develop a quality assessment method. So as you can see and heard from our faculty, it is a subject which is high on the agenda of the EU, and I'm very happy for that. Meanwhile, there have been questions coming in, and maybe I can see, yes, okay. The entire faculty is here with us. So I will just propose questions to each one of you. And I have pulled some questions so that every question is sort of addressed around the same theme. There is a question for Professor Sakrison, Sophia. So you mentioned about the risk-adapted screening. What do you think? Are there actions needed, and is there more evidence needed to move towards this risk-adapted screening? Can you unmute yourself? Oh, maybe someone. Yes. Okay.
Yeah, that's the usual issue you have with those programs. So now I'm on. Yeah, definitely. That's a good question. I mean, there are things that needs to be done before we can move towards a totally risk-based screening. And as you know, I mean, we have now mammography screening since 30 years, more than 3 decades, and it's been surrounded by a lot of debate, because even with this very broadly spread program, it's been a challenge to show that it's actually effective. So by trying to compare with another new method, we need even larger studies with longer follow-up to show if a risk-based approach would be also efficient or even more efficient. So that's a true challenge. So what I think we need is that we have to join forces to decide whether it's actually breast cancer mortality we need to use as endpoint in those kind of comparisons, or if there are other surrogate endpoints that do not need such a long follow-up that could be relevant, like reductions in interval cancers, a stage shift, etc. And of course, taking into consideration the risk of overdiagnosis and false positives. And then finally, it's also an ethical question. Do women want to know their risk, and when should we then conduct this risk estimation, at what age, and how often should it be repeated, etc. So these are questions that need to be solved. But there are initiatives around Europe, but I think we would need to pull them together a little bit more, because we will need big populations and long follow-up to show effects.
Thank you. Thank you very much. That's a very clear message. I have a question for Hans-Ulrich on the lung cancer screening. So you mentioned that the ST, the European Society of Thoracic Imaging, has launched a program on certification for radiologists. Can you share your views about how important is it for us radiologists to follow a certification program, or is it so that radiologists who would already be engaged in thoracic imaging in daily practice could be accurate enough to participate in a lung cancer screening program? So what is your view on that?
My view on this is that we don't have enough chest radiologists with an adequate expertise to run these. And also, if you are a chest radiologist, the way of thinking and sticking to guidelines in a screening program is different from clinical chest radiology. And it's also about training non-chest radiologists and acquaint them with how to detect, measure, and then manage the pulmonary nodules in a lung cancer screening program. And it is especially important for countries who don't have a well-developed and focused training program for subspecialization. So the ST certificate is an offer, especially for countries like Croatia, Poland, Hungary, for a certification that they then don't have to set up on their own. Whereas, for example, the big countries like UK or Germany, they will implement, or the UK already has implemented, a training program to certify their readers in the lung cancer screening programs.
Okay, thank you. The other question that I have also on lung cancer screening. So the evidence is very clear. So we are on the, in fact, on the start of going into this lung cancer screening once the EU and the member states support this. But now the COVID came through, and I can imagine that all of a sudden the urgency is drifting back. And how can we shift back to raise the awareness of doing this lung cancer screening? What do you think we should do as professionals, but also maybe a role for patients or for patient organizations?
Yeah, I think there are three different approaches that we can use. One is that Evelyn nicely showed that cancer diagnosis in total has gone down during the COVID pandemic. So this is a general challenge in all cancers. And as lung cancer is sometimes really progressing quickly, this is an issue that can be addressed. So the general focus on increasing the number of primary diagnosis can be shifted towards this. The other point is that we learned there's much more interest in chest radiology coming from COVID. And although many people realize, okay, probably it's easy and it's pathognomonic to diagnose COVID pneumonia, but in a real world setting, it is not. So we should use this to focus more on chest radiology and what it can offer in lung cancer screening. And I also think that the tobacco role, so risk factors for severe course of COVID and chronic airway disease plus tobacco smoke are also risk factors for lung cancer. So if you want to prepare your lung for being stronger against COVID pneumonia, will also help to reduce your lung cancer risk. So these would be the three approaches that I would see trying to refocus on lung cancer screening programs.
That's very interesting. Yes. Evelyn, there is a question for you. What do you expect will be the effect of this pandemic on the colon cancer mortality?
Yes, so that will depends very much on the delays and the capacity to pick up again. I think in general, having a fit half a year later within a program of, for example, a sequential 2-year program, probably won't have such a big effect like Sophia has shown for breast cancer with many of the same issues. However, what will be a problem is first, if patients will have to wait too long, as I said, for the colonoscopy, because usually they are agitated and nervous once they get a positive pre-test. Others will stay away and will be hiding because they don't want to come during this COVID time. But in general, patients are agitated and want to go. But the other issue is that I think in many countries, there might be a very much longer stop than just the stop we had in my country for a few months. And that, of course, probably there is a certain time where there will be an effect. All of this at the moment is being modeled by my colleagues from the VIEW Medical Center and from the Erasmus Medical Center in the cancer modeling system. So hopefully we will have these predictions relatively soon.
Oh, hopefully, yes. There is a very interesting question that come up, but maybe all of you need to think a little bit about that. And meanwhile, then I will ask a question for Sophia that also came up. So first, the interesting question: does this disruption in screening provide an opportunity to assess the efficacy of screening programs in general? If there is no increase in mortality, does it really support the view against regular screening? Very challenging question. So would this disruption give us more insight in another way? Okay. Meanwhile, well, you have a moment to think about it, but Sophia, there's a question for you. Are you taking into account in your during your 3-decade survey, are you taking into account the risk of radiation from mammography?
I mean, that question was more relevant with the analog systems that were used in the beginning of the mammography era in the 70s and 80s, while from 2000 and onwards, the majority of the programs use digital mammography, which actually gives very low radiation doses. But of course, this should always be thought about, because we're talking about healthy women. The majority do not have breast cancer. And can we impose then a risk of a radiation-induced cancer? Now, there are nice models showing that this risk, there's a minimal theoretical risk of inducing a few breast cancers, but that could really be put on a very low relevance, while the benefits seem to weigh much more. So, but of course, if you think about introducing tomosynthesis, that could, the 3D mammography, that could imply that you have a slightly higher radiation dose, but it will still be much lower than what we had with the older systems. And then in general, of course, we should move towards non-radiation modalities, but screening has to be fast and simple, and ultrasound and MRI are still very time-consuming methods. So, but yes, we do take it into consideration, but I don't think it's a major issue.
Thank you. So back to the last question that I already mentioned, a very challenging one, I must say. Does this disruption because of the COVID in screening provide us an opportunity to assess the efficacy of screening programs in general? If there is no increase in mortality, does it support the view against regular screening? So to the experts, whoever of you would like to pick this question as a personal opinion, maybe?
Mm-hmm. Well, I can just start commenting. I think we perhaps have a median sort of time to develop breast cancer if you compare to lung cancer, which is perhaps more fast growing, and some types of colorectal cancers too. I think a 2-month stop is much too short, like I mentioned in my talk, to even see any effect on anything, both like up or down. So my view is that it would not really give any safe measures on this topic. No, you would need a much longer break to show this effect.
Yes. Yes. Do the others agree, Hans-Ulrich, Evelyn? Yes, Evelyn?
Yes.
Yeah, yes. I totally agree. As I said, it will definitely depend on the length of the stop. But you should also realize that we come from a situation where we had already a screening program in place, and that effect will also take quite long before it is gone. So that will protect most of our individuals as well.
Yeah, yeah. Hans-Ulrich, you wanted to say something?
Yes, same thing. And as lung cancer screening has not really started in Europe, we won't see any effect. So we will have just the same starting baseline to start when we are implementing these programs.
Excellent. So we have run a little bit over time. There are so many questions. So that indicating that this was a very interesting session. And I would like to thank again Hans-Ulrich, Sophia and Evelyn for their time taken to share with us your views. It was very informative. I would also like to point at next week around the same time, we have also an ESR Connect webinar that will focus on the COVID period and how it impacts the workflow in cancer hospitals. So we will have someone, a speaker addressing the Wuhan situation, and the other one, a speaker from the Netherlands Cancer Institute, where we had a system in place where we remain COVID-free hospital. So that's also interesting, and I would like to ask the attendees to also join if they think that that would be a subject of interest. And for now, I really thank you for your attendance, and I really thank the faculty again. Bye-bye.
Thank you. Goodbye.